Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, AAOMPT listeners. Welcome to what I know will be a thought-provoking episode. My name is Helene Bengtsson, and I'm the current president of the Pelvic SIG. Today, I'm excited to be interviewing Dr. Carly Seethaler and Dr. Ryan Vickers on their amazing breakout session held at the 2023 AAOMPT conference called Managing Pain Perception Through Expectancy Violations and Attention Alterations. Here's a little background on Dr. Seethaler and Dr. Vickers before we start the interview. Carly Seethaler received her doctorate in physical therapy from Mercer University in 2022, where she served as the president of the APTA Georgia Student Focused Interest Network, was part of the APTA PT Moves Me campaign, and a member of the ACAPT Leadership Academy Student Leadership Development Subcommittee. Carly completed her Brooks Rehabilitation Orthopedic Residency Program in July of 2023. Carly currently serves as a member on the R.M. Barney Poole Leadership Academy and the Academy of Orthopedic Physical Therapy 50th Anniversary Planning Committee. Dr. Ryan Vickers completed his doctorate of physical therapy at the University of St. Augustine and his orthopedic residency, as well as his orthopedic manual physical therapy fellowship at Brooks Rehabilitation. He currently serves as the program coordinator for the orthopedic residency program for the Brooks Rehabilitation Orthopedic Residency, as well as an instructor for several CEU courses. Ryan is an active member of both the APTA and AAOMPT, having presented at state and national conferences, and is currently acting as a member of the Diversity Network Committee. His specialties include in the management and treatment of patients with chronic neck pain, headaches, and TMD. Welcome, Dr. Seethaler and Dr. Vickers. I'm so excited for you to join me today.
Thank you for having us.
Thank you so much for having us. We're so excited.
I'm so thrilled that we get to talk further about your breakout session. I honestly think this was one of the most thought-provoking breakout sessions I got to attend at the AAOMPT 2023 conference. So to start off, can you give the listeners a brief overview about your breakout session?
Yeah, Helene, again, thank you so much for having us. We were really excited to bring this topic to the AAOMPT conference, and we were beyond grateful for the feedback we got from the audience members there. So I'm really excited to expand a little bit further with you on it today. Pain phenotyping and the impact of psychosocial considerations on nociplastic pain have both finally become hot topics in our profession. And I think it's really important that we continue to research along these paths. But something that I think is equally as groundbreaking and perhaps less considered in practice at this time is the effect of psychological aspects on non-nociplastic pain. So our breakout session was specifically about the perception of pain, considering these psychological aspects and our ability as providers to alter this and pain perception in the central nervous system. And it highlighted a case of one of my patients who had primarily neuropathic and nociceptive pain types who experienced high fear avoidance and anxiety.
Wonderful. So tell me a little bit about this patient, how it ended up inspiring you further into this breakout session. Can you talk a little bit about her anxiety and how that started to affect her, giving you this inspiration?
Absolutely. So when this patient came in, it was one of my first weeks as a practitioner at all, and I was genuinely terrified. She had a paracentral disc protrusion in her cervical spine, and she turned and blocked. She wouldn't really use any body language. She was so fearful of movement. She was in her 30s, super young, and a single mom, and she was told by her physician, one wrong move and you'll be paralyzed. So I was like, what in the world am I going to do with this patient? And, I took it in stride, I would say. I did a little bit of research, but to be completely honest, I had no idea what I did with her when she started to get better. And that's where my mentors really came in. So Dr. James Maggart, who also presented with us at AAOMPT, and Dr. Ryan Vickers, obviously here with us today, really pushed me to look into it. And obviously, as good mentors, they couldn't say exactly what I did, but they did encourage me to look into it. And I just kept saying, this feels so special. It feels like I really did something here, but I really don't know what I did. And they just kept saying, what do you think made it different? So through mentorship, they both inspired me to do a little bit of research on it, on both the attention aspect that we're going to talk about and the expectation part. So yeah, I was inspired to create it because it felt like a component of physical therapy practice that a lot of us already use without knowing it, or if it's not something people are using, they really should be.
So you talk about this anxiety that our patients have. How do you explain how somebody may have a trait anxiety and how it affects our relationship in regards to pain? Ryan, you want to take a look at that?
Yeah, absolutely. So, trait anxiety is essentially a stable personality trait. It's specifically the disposition to have worry, apprehension, sympathetic arousal in a variety of states, whether it's social environments, emotional states, physical environments. It's different from a state anxiety, which would be more anxiety related to a specific event, say getting nervous before you go in for a test. Trait anxiety is really a lifetime of generalized worry and apprehension. So, when it comes to trait anxiety, we actually see a little bit of a difference in how people perceive their pain experience compared to those that have low trait anxiety. Our patients with low trait anxiety are those that we can usually distract from their pain. So, you can think about those patients where they struggle to do an exercise because they say it hurts, and then you start chatting with them, and all of a sudden they're able to do the exercise and they have no pain. These patients can be distracted from their pain, and if you're telling them ahead of time that they're going to experience some pain, that'll actually help reduce their pain experience. High trait anxiety patients have the opposite effect when it comes to dealing with their pain perception. So patients with high trait anxiety tend to be very hypervigilant to their pain, and when it comes to choosing between attention towards a painful stimuli versus a neutral or positive, they do tend to selectively attend towards their pain. So we can't use distraction as well as to effectively get them away from experiencing quite as intensive pain. These patients will also experience increased pain with anticipation. So we're not able to kind of prep our patients and say, hey, if you feel a little pain with this, that'll be okay. For someone with high trait anxiety, that would actually make their pain experience worse. So when it comes to management of pain perceptions with those with high trait anxiety, one area that researchers are looking into is using the dual processing theory. So the dual processing theory essentially states that in any environment, anytime we're processing a situation, there's two buckets that we're dealing with. One bucket being the implicit, subjective, or emotional bucket, and the other being the more explicit, cognitive, or sensation. So in the case of pain experience, the emotional bucket would be more worry associated with the pain or frustration that the pain is still present. Versus the sensation would maybe be how that pain actually feels. Is it a stretching, a pulling, an aching sensation? What's really interesting is that when they've done studies with patients with high trait anxiety, and they've broken them into two buckets, focusing on these two areas of the dual processing, those that focused on their sensation tended to do better. So in one study, they did a cold water immersion bath and looked at their pain experience and how long they could tolerate the cold water. Those that focused on the experience of cold actually tolerated the water longer and had less pain than those that were told to focus on the actual intensity of their pain experience. So just by using our ability to have our patients focus on elements of their pain, we can actually see changes in how their pain experience occurs, but it's dependent on their trait anxiety levels.
That's quite interesting. So it sounds like there's a change to where they're focusing their attention, right? So, Carly, what do you feel like you used in your patient that allowed you to use this thought of trait anxiety and dual processing and attention with the patient that you saw?
She basically presented with high trait anxiety. She was prescribed medication to manage her anxiety and it didn't do a great job. So with what Ryan just talked about, it wasn't to our benefit for us to allow her to ruminate on her pain. So for this patient, I use selective attention given to pain versus form, where we set a number of pain and we focused on that number that she was comfortable with performing activities. So she wanted to go back to the gym and deadlift. We would practice a deadlift in the clinic, and she would set her comfort pain level beforehand. And instead of her focusing on the sensation of her pain, she would provide that selective feedback to me of, this is a 4 out of 10 now, so I need to stop. And she would focus on the number it was, not the sensation. And we focused on the form, which that might be controversial in terms of, does form matter? But in this case for her, giving her an external focus was really important. So we would do her deadlifts in the mirror and she would focus on what her form was instead of her pain. She used pain as is this a warning or is this a miss signal? Am I being told that this is painful because I'm fearful of this, because I have anxiety doing this activity? Or is this really I'm in pain when I'm doing this? And I think having that distinguishing factor was really, really important for her.
How were you able to teach her to be able to distinguish that, especially since I find often with patients in the clinic who do have that high trait anxiety, sometimes it's hard for them to step back and take that third person view on themselves and say, okay, this may be more of my anxiety and the anticipation versus maybe I am experiencing pain and I do need to take myself back a little bit.
Yeah, I mean, I think that that's something that we have to adjust per patient. And, obviously each patient is different with this. And I guess that's the PT answer, right? It depends. But for her specifically, when her pain became neuropathic, when she had that referral of symptoms down her arm, that was the most disconcerting to her. So if we were able to just have pain in the neck and not have any referral of symptoms down her arm, she was happy with that. She was fine with that. And so for her, it was, is this pain something that is muscular? Is it your muscles taking over? And it just took a lot of repetition, I would say. I mean, I saw this patient for months and months and months, and it was a very inconsistent case, as a lot of our patients with high anxiety tend to be. I mean, things come up, and she was a single mom, so she had a lot going on. And so for her to be able to take what we did in the clinic and apply it in her life, I think was the most important aspect of all of this. And right when she came back into the clinic, if it had been a week or so that I hadn't seen her, I'd ask her, what did we talk about last time when it came to your pain and how it relates to your anxiety? And so she would re-educate me on that. And that's, I think, how we had that carryover. We just talked about it every single time she came in.
That's wonderful. So, one of the things that I loved about your breakout session was the concept of expectancy violation. You see these patients walk in, they have super high trait anxiety. You need to use other ways of helping them cope with the pain that they're having. And you started talking about expectancy violation. Would you be able to talk about that and define what that is?
Sure, I can go into that. So this was actually new terminology for me as well when I first came across the literature that Carly's other mentor, Dr. James Maggart, brought to our attention. So it actually is a concept and a term that's coming from our behavioral therapy partners. So expectancy violations is defined as a mismatch between an expected outcome and an alternate actual outcome. So the idea here would be if someone is expecting to have a painful response to a certain movement pattern, and then they do that movement pattern and they realize it's not painful, that would be an expectancy violation. So this technique is used specifically during exposure therapy to help reduce fear for patients that are undergoing behavioral therapy. But in physical therapy, we could use some of these elements as well. Now that physical therapy is starting to use more psychosocial assessments and starting to recognize the impact of fear avoidance on patients' musculoskeletal impairments, we're starting to realize that there's more that we could potentially be doing here beyond just screening these patients. This is where we can do an assessment and now we have an intervention we can apply. So we can use graded exposure as a way to address fear avoidance behavior in order to create this expectancy violation. They're expecting something to be painful, so we expose them to that movement pattern. We expose them to maybe lifting a weight. Maybe it's moving in a way that they're unaccustomed to. They don't have the symptoms that they expected, and now we start to see change. The biggest catch with expectancy violation is that the patient has to be made aware that the outcome was different than the outcome that they expected. So this is all about learning. So if a patient just does something and doesn't learn from it, that expectancy violation hasn't really occurred. So in order to really achieve expectancy violations in physical therapy, there has to be a pre-discussion with the patient before an activity, find out what the patient is expecting, have the patient do the activity, and then after the activity, discuss with the patient what the outcome was, and was that different from what they originally expected to occur. And that's when we can really start to see changes to how they're experiencing some of these fear avoidant behaviors.
That sounds wonderful. Carly, I keep going back to your patient because she sounds so interesting. So, when you put it all together, we talk about the neuromodulatory gains that we make with patients. Where do you find the connection between the expectancy violation into the attention, and how does that work together?
Yeah, great question. So I think in terms of these expectancy violations and attention, we can use an expectancy violation as our way to remove attention from pain. And I think something really important to talk about here when you brought up the neuromodulatory gain is what that really is within the central nervous system. So I'm going to popcorn to Ryan and have him kind of go into the nitty gritty a little bit about what neuromodulatory gain is, so we can then talk about how that is actually affected by expectancy violation and attention changes.
Yeah, so neuromodulatory gain is a concept that we probably are familiar with but have never heard the word for. So neuromodulatory gain is the sensitivity of a neuron to changes. This essentially means that our nerves have the ability to change how they respond to inputs and how they provide outputs. So we all remember from our basic neuroanatomy courses that we've got our interneurons that can influence our nervous system to cause either an excitatory or an inhibitory response. This changes how much stimuli our nerves need to fire. Similarly, though, we can also impact the way our nerves are creating outputs. So we can modulate how much of an output a nerve has once it has fired. Neuromodulatory gain is incredibly important because our nervous system has to be, at the same time, incredibly stable because it's got to be able to keep us alive. It's got to keep all of our body systems functioning, while at the same time adapting and evolving to ever-changing environmental stimuli and factors. We're constantly being exposed to new stimuli that our nervous system and our brain has to adapt to. And so by having this ability to fluctuate the capacity of the nerves, this allows for our body to be able to change and adapt depending on the environment that we're in. Neuromodulatory gain is really all about enhancing our ability to encode information in the brain and then be able to learn in different environments. And this is going to happen in specific instances when that neuromodulatory gain is enhanced. So different stimuli that will increase neuromodulatory gain would include things like arousal, attention to specific stimuli. Walking can actually increase our attention, and that'll increase our neuromodulatory gain. But really, at the end of the day, it's anything where our brain is needing to learn. So novel stimuli or environments is going to drive this neuromodulatory change to start to enhance what our brain is able to learn from the environment.
So, with that all in mind, the basis of the research behind all of this is neuromodulatory gain. So, there was a study published in 2017 in the Neuroimage Journal by author Francesca Fardo and colleagues, and it discusses the interaction between expectancy violation and attention and our central pain processing pathways. The researchers performed expectancy violations by providing 3 to 7 stimuli to participants' radial nerves, switching at randomized intervals between the left and the right hands. So as a participant, you would sit in a chair, and let's say it started with your left hand, and you receive 5 radial stimuli at that point. and then it would switch to your right hand without your awareness. So the first stimulus on your right hand would be that unexpected stimulus. And at that point, you'd be asked to rate your pain on the visual analog scale. And then after a few stimuli on that same hand, they were then at that point considered the expected stimuli. So you would be asked again to rate your pain on the visual analog scale. And then to manipulate the participants' attention in this study, there were two groups. One group of participants was asked to count the number of stimuli each hand received, and they would report the number on each hand after it switched. And then the second group was asked to look ahead at a color changing cross on the wall, and they were asked to count throughout this entire process how many times the cross changed colors. So both of these groups, again, there was an accepted error for each of these reportings, and to ensure there was an appropriate attention given to either the radial nerve stimuli or to the cross on the wall. But each group was asked again to rate their pain on the visual analog scale. And what the researchers found was that the unexpected stimuli and the attended to stimuli were both significantly more painful per the reportings on the visual analog scale, more so than the expected stimuli and the unattended to pain. And I think that's pretty cool, but what I think we all could do is predict that response, right? The most interesting part of this study to me is that the researchers actually used magnetoencephalography with these participants. So what that is a functional neuroimaging technique for mapping brain activity that records magnetic fields produced by electrical currents occurring naturally in the brain. So basically, these neuroimages found that expectation and attention both alter the neuromodulatory gain in the somatosensory cortex, which is huge because we know that is one of the main areas for pain processing. Simply put, we're changing the brain's understanding of pain by using expectations and attention when we treat our patients. And what's potentially even more exciting about all of this is that newer studies have found that these neuromodulatory gain changes affect not only short-term adaptations, but you see long-term changes as well. So not only are we using these principles to affect pain processing in the moment with our patients, but this could have long-term solution for establishing pain coping mechanisms within our patients.
So my question to you is, since you say it's kind of future, how do you feel like this entire concept is going to change the way we practice?
I just think that this is something, as I said, a lot of people are already using and aren't aware of it. And so I think if we can just bring the attention to what it is and what we are doing, it will not only improve our practice, but it will prove our metacognition. It'll make us aware and reflective practitioners of what we're doing with our patients. Not only that, but for people who aren't currently using this, for new practitioners entering the field, these are simple techniques. You have to take the time to talk to your patients and to understand their fears and their beliefs, because if you don't take that time and establish the trust with the patient, you've completely lost the potential to make these huge, long-lasting effects. And if we don't take the opportunity to do that, we're doing a disservice to our patients, and all we're doing is treating their impairments.
I think what's also really cool is that as OMPTs, we're really posed as some of the best providers to be able to provide interventions in this world. We're spending more time with our patients than most providers ever get a chance to. We get more time one-on-one to be able to talk with our patients. And this is really going to be an opportunity where we can combine some of these elements of what we understand about the brain and psychology with our specialty, which is human movement and musculoskeletal function. So it really sets us up to be the providers that are the ones who can help in this aspect for our patients.
That sounds wonderful. Is there anything else you would love for the listeners to learn and understand about your entire breakout session, and anything else that you want them to know to take home with them today?
I love this question. I think that that's kind of where I never saw this going. When I was just making this breakout session with Ryan and James, we were excited to do it. We were hoping it would be well received. But what I think came out of this in the end was the impact this might have on our practice. And I really, really want people to continue to look this stuff up, continue to research it. It's new, it's novel, it's developing now. So do the research on it. Be the person who does the next case report on it. Be the person who performs the next research study that assesses your expectancy violations and your attention. It's a call to action, I would say, for practitioners to put the onus on themselves to put this to use and then tell us all how it worked, because we have the potential for change in our practice and to make big impacts on our patients' lives. And if we use something like this to make those long-lasting effects, then our patients will be better off for it in the long run, and our practice as a whole can skyrocket.
Thank you for that answer. I just want to say thank you so much, Carly and Ryan, for joining me today. It has been such a wonderful conversation, and I am so grateful for you guys that you made such a wonderful breakout session and now even another episode so our listeners can hear more about managing pain perception through expectancy violations and the attention alterations. Thank you, guys.
Thanks so much.
Thank you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.